Lastly, I am not Paul Ridker. Paul had to, as you can see, Paul had to be in Boston to take care of his mother who has some health issues. But I am here on behalf of many of the audience who were also involved in the clinical trial, the prominent trial. And it's been a very long journey, which began, I think, in 2015, perhaps, with Peter and Paul and Jean-Charles meeting together and coming to Mr. Miwa, who is in the room as well here, and getting support, growing support for this trial that I believe will be a landmark trial to try to understand how PPAR alpha agonism influences metabolic changes associated with type 2 diabetes and dyslipidemia. So I do want to thank Jean-Charles and Jamila for allowing me to be here today to tell you this data. And I have a lot to explain after Dr. Yamashita showed you what the phase 2 data were for this drug. So let's go through the phase 3 data. All right, let's see if I can do the job. So all of you know this, and I think by way of background, I do want to give a due credit to many in this room, many who are not here today, who developed over the past several decades the idea and the observational data to support the association between triglyceride levels and increased cardiovascular risk. And certainly these data from Borja Nordesgaard were some of the landmark data which demonstrated that increasing, and in this case, non-fasting triglyceride levels were associated with each of the major cardiovascular endpoints that we care about in the Copenhagen study. And it is also very clear that when you pool analyses, that a consistency in the observational association and the observational data sets suggests that overall about a 72% increase in coronary heart disease risk for an increase in the top third versus the bottom third in this pooled analysis of over 29 studies. And it didn't depend whether the duration of follow-up, whether you're male or female, fasting, non-fasting status, and even, yes, if you adjusted for HDL cholesterol or not. This increased association was very consistent. I don't think I need to tell this audience, but some of you, I think, are a little bit new to this idea of why remnant cholesterol, why we measure it, and what the assays are, which I'll go through in a moment. But we know that an individual with hypertriglyceridemia has triglyceride levels in many of these different particles, and it's hard to tell, just given the triglyceride level, what the amount of cholesterol carried in these particles is. Therefore, we've moved towards measuring remnant cholesterol either by the calculation, total cholesterol minus HDL minus LDL cholesterol, which is the easiest and most accessible to most clinicians, or by using various assays. So what we did in this paper, published in 2021, is now as we've moved away from triglycerides, moving towards remnant cholesterol, let's see what the epidemiology told us about this risk association. Was it the same as what we saw for triglyceride levels? And this is just the data now on fasting triglyceride levels that showed early on that if we are using these highly intense, resource-intensive methods of measuring remnant cholesterol in multiple cohorts, what you did see is about a 1 to 2% increase in risk per 1 milligram per deciliter increase in triglyceride levels. And that's whether you use the immunoseparation, ultracentrifugation methods, or the vertical auto profile, I believe is what it was called back then. And what then came along is the direct assay that we were talking about earlier today. This is an assay that measured, it was a first generation assay that was used in the ARIC trial study, and you can see that there was no risk association using that assay and cardiovascular outcomes. So this first generation assay showed no significant association. That assay was further developed, revised, modified, and we have some more data on risk association, which I'll show you in just a moment. If you look at the calculated values, and this has been mentioned before, there's this sort of interaction with statin, randomization to statin in the TNT trial. In those individuals who are randomized to low-dose atorvastatin, about a 50% increase in association with remnant cholesterol, but no significant association if you are on a high-intensity statin, and thus begins this conundrum of statin interaction with cholesterol, with remnant cholesterol actions within the body. Okay, so if we look at non-fasting remnant cholesterol, we have a number of studies that have now emerged, and these have used either the calculated methodology or the NMR methodology, and finally the second generation assay. All of these show, and you don't need to look at the individual estimates, all of these show an increased association, even with the second generation assay, with increased cardiovascular events. And the takeaway I want you to remember is that over 15 publications, whether fasting or non-fasting, variable methods of measuring remnant cholesterol, now moving towards NMR and second generation assays, do show a consistent association. However, the optimal method of measuring remnant cholesterol, as Marsu mentioned earlier, is unclear. These strong associations really across many diverse populations, really with only a few exceptions related to the assay. Okay, we've had some elegant talks about how triglyceride-rich lipoproteins and their remnants promote atherosclerosis. And I think largely theoretical, I would say. Probably the evidence is still accumulating, but we know that nascent VLDL particles secreted in the plasma, and those also from the intestine, undergo intravascular lipolysis through this delipidation cascade, as you can see here, and then ultimately land in the LDL compartment, either entering the vascular endothelium directly or as remnant particles which below a certain size limit can also transfer. And this action is enhanced by lipoprotein lipase and to some degree also by hepatic lipase. That's the theory and the basis for the trial and the types of drugs that we try to use to intervene on this process. So the cholesterol payload is then delivered either by LDL cholesterol or by these triglyceride-rich lipoprotein remnants that are now small enough to get into the subendothelial space. Also very important, genetic information that again gave us the robust understanding that lipoprotein lipase is the central factor in this process, that inhibitors of lipoprotein lipase, loss of function mutations in these three proteins, are associated with a lower risk of cardiovascular events, and then gain of function in ApoA5 or loss of function in ApoA5 is associated with an increased risk of cardiovascular events. Same to loss of function lipoprotein lipase. The gene itself is associated with an increased risk of cardiovascular events. So let me just take you through some data which have been mentioned already. What happens with the ApoC3 mutation? So these data shown on the left, what I have here is the mean triglyceride level among non-carriers, and then you can see that the mean triglyceride level among carriers of the loss of function mutation is much lower. And then if you move forward, you take these 4 mutations and look in prospective cohort studies on incident cardiovascular events, what you see is that if you aggregate the data, you see about a 40% reduction in risk with a loss of function, any one or more of these ApoC3 loss of function mutations. So again, implicating this pathway, we now have the observational data, we have the genetic data, we have the theoretical data, and some of the physiology to support this pathway. So that was the rationale, and some other observations that really at this time catapulted the field is that while triglycerides are associated with cardiovascular risk, we did not know whether triglyceride reduction at that time in 2016, whether TG reduction would yield a benefit in terms of cardiovascular event reduction. And despite a 20 to 30% reduction in triglycerides with prior strategies, including fibrates, niacin, purified omega-3 fatty acids, these showed either no significant reduction in risk, or in the case of Reduce It, a risk reduction that did not show any linkage with triglyceride reduction. So what's happening there? Mild to moderate hypertriglyceridemia in the 150 to 499 milligram per deciliter range is common in patients with type 2 diabetes. It's 1 in 3 statin-treated patients. And mild to moderate hypertriglyceridemia subgroups in the prior fibrate trials showed a benefit from fibrate therapy. And that's shown here. I'm going to skip through this. You all know this. The major trials, if you looked at the subgroup with dyslipidemia, big benefit. Subgroup without dyslipidemia, no benefit. What the drug, is very nicely described in the previous presentation by Dr. Yamashita, has effects both on increased production. It suppresses triglyceride secretion with decreased plasma levels of triglycerides due to an effect on the liver, and then also through promotion of LPL activity because of a decrease in ApoC3, leading to increased catabolism. It also has some effects on HDL raising as well. And in the phase 2 data from Dr. Ishibashi and Dr. Yamashita, you can see here that there was a 40% reduction in triglycerides and a 20% increase in HDL that was expected in this trial for the doses used in the outcome study. So the trial was performed in 24 countries. Many of you in the room were involved with that, either as steering committee members or as executive committee members. 100% type 2 diabetes, mixed dyslipidemia, high triglycerides, low HDL, background-directed guideline use of statin therapies to lower LDL in this high-risk population. 1/3 were primary prevention, 2/3 were secondary prevention, and after a placebo run-in period, they were randomized to 0.2 milligrams of pemafibrate or to placebo, and then followed with the intention of going out to about 4.5 years for cardiovascular disease endpoints. It would stop at over 1,300, and we ensured that we had the ability to detect the harm seen in a cord, if there was one, by mandating over 200 events in women. And it was powered for 16.6% risk reduction. The composite was MI, ischemic stroke, coronary revascularization, or cardiovascular death. Pre-specified safety endpoints, as in any clinical trial, investigator-reported adverse events, laboratory parameters, renal adverse events, venous thromboembolism, and then one of the key exploratory endpoints was also non-alcoholic fatty liver disease. The major inclusion criteria: type 2 diabetes, triglyceride level 200 to 499 with an HDL less than or equal to 40 milligrams per deciliter, either established coronary, cerebrovascular, or peripheral artery disease, or in the absence of that, age over 50 for men and age over 55 for women. What's shown here is important, the statin treatment. As you've seen, there is some question of this interaction with statin therapy and the achieved triglyceride reduction, the achieved LDL changes, all of that. In this trial, because we wanted to have a look at pemafibrate on top of maximal statin therapy, we ensured that the patients were on a moderate or high intensity statin, that if they were on another lipid-lowering therapy, their baseline LDL, they had to have evidence of an LDL less than 70. And then if they had statin intolerance, you couldn't get in unless you had an LDL less than 100 milligrams per deciliter. So you'll see that emerging in the characteristics that I'll show you. The usual key exclusion criteria, I'll mention liver disease as well as renal disease with an eGFR less than 30 was an exclusion criterion. So we screened 35,000 patients and we recruited on time to randomize 10,497 patients. As Peter mentioned earlier, we ran into both the COVID-19 pandemic and both the disruptions in Eastern Europe with the conflict there as well. Nonetheless, throughout the course of the trial, we had very few withdrawals of consent, very few loss to follow-up, and vital status was obtained in over 97% of individuals in the trial. The baseline characteristics reflect a high-risk population. The average median age was 64, with an average body mass index of 32. Diabetes duration of over half had a duration over 10 years, 28% female, which we thought was cause for celebration. You, of course, all know that that's not where we should be at, but 28% female, 19% Hispanic ethnicity, and then high prevalence of hypertension with a median A1C of 7.3 and a median CRP of 2.3 in the high range. In terms of other background medical therapy, I'll just highlight any statin, 96% on any statin, high intensity statin, 69% of the population. And then GLP and SGLT2 inhibitor use were just coming on board at that time, but we did have sufficient numbers of patients at baseline and have not looked at that data carefully, but there was very little differential drop-in. The triglyceride median, this is also important. Higher than reduce it, higher than strength, 270 milligrams per deciliter, and may, as I've been learning today, explain some of the increase in LDL cholesterol. That higher triglyceride level, you put them on an agent like pemafibrate, you may actually get a much higher increase in LDL cholesterol. HDL, low. LDL, importantly, also low, 78, 79 milligrams per deciliter. We achieved our goal of getting at least LDL controlled. And then importantly, for those of you who know what a 15 milligram per deciliter value for ApoC3, I'll share with you later that's sort of in the moderate range for ApoC3. Compliance was good, 82% mean compliance and 75% taking over 80% of their pills, but most importantly, what's on the left-hand side, no difference between the two groups in terms of compliance to therapy. So here are the results that if you saw the New England Journal paper, you saw this. So there are importantly, within group differences, there were trending down, probably regression to the mean for a reduction in triglycerides, 6.7%, 10% for VLDL, 20% for remnant cholesterol, ApoC3, no difference. And then shown here are the within group for pemafibrate, the percent change in the median. The treatment effect is the important number, 26% reduction in triglycerides, 26% reduction in VLDL cholesterol, 26% reduction in remnant cholesterol using the DENCA assay, 28% reduction in ApoC3. Important to know as we talk about percent, you all know this, that if you start at a lower value, the same absolute change will result in a bigger percent change. So keep that in mind as we look at these data in context of everything else that we've talked about today. We did see this. So evidence of an interaction such that patients on the low-intensity statins had a greater reduction in triglycerides. Moderate, and this was a linear, sort of a linear effect, 28.5% in those in moderate intensity and 24% those in high intensity. So if we think back to what Dr. Yamashita had presented, if those populations had more low intensity or moderate intensity statin, you'd expect a bigger change, percent change. And in fact, if their triglycerides were lower to begin with as well, the percent change would be bigger for the same absolute change. But we want to look at the absolute change over time. So what I'm showing you here is over time, the difference in triglycerides for placebo and for pemafibrate, and then remnant cholesterol and pemafibrate. And you can see that there was a 40 to 50 milligram per deciliter absolute lower triglyceride level and a 10 milligram per deciliter absolute lower remnant cholesterol level that was persisted throughout the course of the trial until the washout period, 30 days after drug was stopped. Total cholesterol, HDL cholesterol, LDL cholesterol, ApoB, I think the value that really stuck out like a sore thumb was the 12% increase in LDL cholesterol and about a 5% increase in ApoB associated with treatment. And here are the curves then for pemafibrate and placebo with an increase in LDL cholesterol, 10 milligram per deciliter, and a 5 milligram per deciliter increase in ApoB. You, of course, all know and have seen these event curves. So for the primary endpoint, no significant difference between the two groups for a hazard ratio of 1.03. Important to note, though, that this population was very high risk, 10% event rate at 3 years. So the markers, the triglyceride levels, enhanced the risk of this population. I think we, in terms of residual risk, which we're all here about in type 2 diabetes, that's an important point to take home. There was no increase in total mortality, and I think you'll see over the course of the next few slides that, in fact, the drug was quite safe, with the exception of one or two sort of anticipated issues that we knew from other agents, other PPAR alpha agents. A lot of endpoints that we adjudicated in the trial, and some of you may be more interested in some than others, but I think you can see overall the hazard ratio about 1.0 throughout. I think some have been interested in heart failure. No significant difference in heart failure when added to the primary endpoint. Now, you're not supposed to read this, but this is the subgroup analyses. These were all pre-specified, and you can see that the hazard ratios line up around 1 for every pre-specified subgroup. And importantly, if you're wondering about men and women, no significant difference. If you're wondering about primary versus secondary, no interaction there. And even for high-intensity statin, no difference there by baseline intensity of statin use. So for the safety results, for any serious adverse events, no significant difference between the two groups. As I want to emphasize, the drug was quite safe. No increase in COVID-19 infections, no benefit from this therapy on COVID-19 infections, no increase in myopathy, musculoskeletal events, even though most of these patients were on a high-intensity statin. A numerically increased, twofold increase in venous thromboembolism events, but it was very infrequent in this population. In terms of renal adverse events, a slight increase in what was called a renal adverse event by a physician investigator. But if you look at the eGFR and creatinine levels, you see that while there was an increase in both sort of declined over time, the creatinine eGFR was lower in the pemafibrate group, but reverted back to normal, just as what has been observed with fenofibrate. And same too for creatinine over time. So whether this is toxic effect. I think none of us here in this room would consider that to be the case, but why creatinine levels go up is not very clear to me, and I don't think has been very well worked out. So for non-alcoholic liver disease, one line about that, there was a 22% decrease in investigator-reported non-alcoholic liver disease with a hazard ratio of 0.78, 0.63 to 0.93 for the confidence interval. Okay, for summary of the main trial, and then maybe take a deep breath, and we'll try to deconstruct this process that's been 20 years in the making in the next 5 to 10 minutes. But for the main trial, we concluded that while pemafibrate reduced triglycerides, reduced VLDL cholesterol, reduced remnant cholesterol, and ApoC3 by 20 to 30%, it did not reduce cardiovascular events in patients with type 2 diabetes, mild to moderate hypertriglyceridemia, low HDL, and well-controlled LDL. And there was no significant interaction, no significant subgroups that we had pre-specified that derived a benefit. There was an increased signal for renal adverse events. We obviously are going to be looking at that more carefully because with COA support, we have albumin levels measured in urine in all of these patients over time. And there was a slight increase in venous thromboembolism with numerically low event rates. And of course, the observation for a reduction in hepatic adverse events and non-alcoholic fatty liver is being investigated in other more precise studies being conducted in Japan. Okay, so how are these results being viewed? So you often don't know how your results are being viewed by the public because your friends, all of you here, might say good things, right? So I was looking through Twitter feeds, people were sending me information from social media, and this is what we got. So perhaps it's time to conclude that triglyceride levels are a marker of risk, but not a causal factor in cardiovascular disease. Maybe for triglycerides, but we've heard some very important arguments against that for remnant cholesterol. Epidemiology, again, and genetic association studies now fail to deliver. I'm not a genetic epidemiologist, but there was strong evidence that if you reduce ApoC3, you should get a benefit. If you reduce some of these other markers that we measured, you should get a benefit. It's time to abandon fibrates. It's the second most common lipid-lowering therapy as they deliver no cardiovascular benefit and increase polypharmacy. That definitely has been a concern, but as we've all talked about today, there are other potential benefits on microvascular disease, on end organ dysfunction, that we need to consider with these agents as well. And whether the trial elucidates those associations benefits is waiting to be seen. The last two quotes are interesting. We can use triglycerides as a classic teaching case of reducing surrogate markers like HDL that don't translate into clinical benefit for our patients. And that was from a well-known cardiologist who doesn't believe in statins either. So resoundingly clear, it's all about ApoB lowering for addressing atherogenic lipoprotein-related risk. We've heard arguments that it's not, every ApoB is not the same, and there could be another group of individuals, very well-known individuals, who would argue that each ApoB molecule is the same no matter where it resides. So there's a lot of controversy to go through here. I wanted to give you, in the last several months, as I've been digesting the data, my take on some of this and see if it resonates. I think after listening to those elegant talks this morning, my views and my take on this complex physiology is not completely informed. My picture is incomplete, and I would value your input. So we know that these processes are very complex. We saw a lot of diagrams this morning that had arrows that and names of cofactors and things that I think can be confusing to many of us clinicians. But Importantly, there are many factors at play with the triglyceride level that one measures in the clinic with the remnant cholesterol. If we ever get an assay that works in the clinic, it's the assembly, the secretion of these proteins, it's the remodeling during the delipidation cascade, and importantly, it's the clearance as well. There are many destinations for these lipoproteins. And this is going to look very simplistic and probably pediatric when you think about what Chris Packard showed. But in my view, when you look at the plasma triglyceride levels, the things that determine plasma triglyceride levels are the constitution, liver-mediated, and now we know intestinally secreted as well, conversion through LPL-mediated pathways that get us to LDL ultimately, also influenced by hepatic lipase, but the major ones, liver-mediated, LPL-mediated, and then clearance through several proteins that I searched far and wide to determine what was out there published on remnant receptors. And the data are mixed and very muddy in terms of what receptors are responsible in pathways for clearance. So it appears to me that in this trial, what we saw is a reduction in triglyceride levels, perhaps through constitution and then through conversion, leading to an increase in LDL, but not as much clearance of this LDL that would allow for a benefit on macrovascular events. That's my theory, and I think it would be worth a healthy discussion. So it might be helpful to know what happened in other fibrate trials for LDL. So if you look at that data, I just aggregated this to answer the question, were increases in LDL cholesterol or ApoB seen in prior fibrate trials? And I classified them according to the drug, just you can see in lighter, progressively darker blue bars here, or rows here. And then there are different durations of follow-up, certainly. Most of these are within group comparisons. And what I'll show you are the mean triglyceride and the percent change. I'll show you as well the mean LDL and the ApoB. But looking at the mean triglyceride change, you can see fairly between 20 and 40%, probably related to the population, the starting triglyceride, et cetera. But that's not the most important point. What do we see when we look at the mean LDL change? For the most part, we see, if anything, a reduction in LDL. And for the mean ApoB change, we only have a few studies that show conflicting results. So what does that mean? Important to note that most of these did not select for high triglycerides, right? So the pathways that Chris was talking about may not have as much of a role in terms of the LDL conversion. But so these patients had usual triglyceride levels. You can see in HHS for gemfibrozil, the LDL level came down on gemfibrozil. For VA HIT, this was the only trial in which there was no significant difference with gemfibrozil. Here with bezafibrate, a reduction in LDL. Here with fenofibrate in DIAS, a reduction in LDL. And if you look at the LEADER trial, which was bezafibrate, a reduction in LDL with bezafibrate. Busy slide, but if you look at the field study, remember the total cohort, and then there were those who dropped into statin therapy and those who did not drop into statin therapy. This is the overall difference between treatment groups, a lower LDL throughout the course of the trial, and those assigned to fenofibrate, whether or not you had uptake of lipid-lowering therapy, with, if anything, a lower reduction if you started statin. So not very clear to me what's going on here. And for ACCORD, no significant difference in terms of LDL reduction. So what do we make of this? Let me remind you what happened in PROMINENT, that we had a 10 milligram per deciliter increase in LDL, and that we had a 5 milligram per deciliter increase in ApoB. Putting this all together, could it be that this is pemafibrate's action on conversion, activating that delipidation cascade, but without clearance of these particles, and also that LDL particles that are generated in this process live longer in the circulation. They take longer to degrade. So the values that we measure are related to this delipidation process rather than a direct pro-atherogenic effect of the drug. It's telling us exactly that the drug is working. It's doing its job. Okay, what about ApoC3? And we can discuss all these a little bit later, but what about ApoC3? So in the pivotal study that was mentioned in the New England Journal, the loss of function mutation carriers on average had about a 40% reduction in triglycerides, so much higher than what we saw, and a 46% reduction in ApoC3. And if you look at the event curves over time, according to the baseline level of ApoC3, prominent participants squarely in the red line here, and this is freedom from coronary heart disease, we stopped the trial at 3.4 years, where there was potentially not enough time to see the benefit of the drug of that 20% reduction. So it's possible that we needed a longer period of follow-up. We would have shifted, for instance, our patients would have shifted for the most part from this curve to this curve, which would probably have taken much longer for us to have an emergent benefit. And that's the hazard of stopping trials early. The last thing, we didn't talk much about this, but I think we all need to acknowledge that there are other agents that have massive reductions in triglycerides, that have benefits in LDL lowering, that may even have benefits in terms of hepatic fat accumulation, and those are the RNA inhibitors, the mRNA inhibitors. Shown here are data that were published, actually not published yet, just presented at the American Heart Association last year, and this was starts with an E trial, but it's in a small interfering mRNA molecule, and very similar study population, injectable 0-12-week data being presented. They also looked at MRI PDFF as well, and I think they presented that data suggesting a potential benefit there. But what I want to show you here are the data for ANGPTL3 and triglycerides. You get a marked reduction in triglycerides at the maximal doses of this drug, 200 milligrams, and then you get a 50 or 60% reduction at the maximal dose of this drug as well at 12 to 16 weeks on this injectable agent. And then if you look at LDL cholesterol, about a 30% reduction in LDL cholesterol, about a 35% reduction in non-HDL, and remnant cholesterol as well comes down 47% or so, with a mean ApoB decrease that was significant, as you can see, compared to placebo. Okay. These are just some summary thoughts. We'll have more time for discussion, but triglyceride-rich lipoprotein metabolism is complex. There's a lot that we don't know. A lot depends on the starting triglyceride level, the starting values before you initiate therapy, and what other agents. This statin interaction, I think, is something we really need to understand as many of our patients are on this therapy. It's possible that beyond this triglyceride-rich remodeling, we need enhanced clearance, which was the focus of some of the talks this morning, to neutralize residual risk. And increased LDL, likely through conversion, although I could be convinced it's something else, and ApoB, that increase may negate the benefit that we saw. Ongoing trials of alternate and potentially more potent, but we don't know the safety yet. These altered agents that include ApoC3 and ANGPTL3 inhibitors may come online, and we may be looking at those agents in this population. But I do believe that we are closing in on the biology. After today, I'm not so sure. I usually say we're closing in, but I feel like we have so much more to learn. You all, and one of the beauties of this meeting is that we have lipidologists, we have clinicians, we have nephrocardiologists, we have PhD scientists that can all help us break down what's going on and help us advise for what's next on the horizon for these patients. So I'll stop there. Thank you very much.